Hi class, we are going to discuss endocrine system in this video. I'm going to do my screen share. You can watch. Some of it is just the same PowerPoint which I've sent you. If you have reviewed the PowerPoints before, great. If not, then we're going to review it together. Okay, so this is the PowerPoint from Professor Robbie Lee, and this talks about endocrine drugs and pituitary, thyroid, parathyroids, and adrenal disorders. All right. So pituitary gland is also known as hypophysis. It has two lobes. We know anterior and the posterior lobe. So anterior lobe is adenophysis and posterior lobe is neurophysis. It has multiple secretions. What are different secretions or hormones that are secreted through anterior pituitary? That is a growth hormone that stimulates the growth in the tissue and the bones, using the growth hormone to build muscle mass, and it is not recommended because of its effects on the blood sugar and other side effects. So growth hormone is technically a hormone that helps a person to increase in growth, right? So it helps a person to grow. As it says, growth hormone. Growth hormone is a hormone that will help a person grow. Next one is thyroid stimulating hormone, something that will stimulate the thyroids that are present right on the neck. All right, so thyroid stimulating hormone is TSH. It acts on thyroid gland. Excess TSH secretions causes hyperthyroidism. Deficient TSH secretions causes hypothyroidism. Hyper means more, hypo means less. Adrenocorticotropic hormone. Adrenocorticotropic hormone is something that will stimulate the adrenal glands. And gonadotropin. Gonadotropin is something that will stimulate gonads in order to produce FSH and LH, estrogen, progesterone, and testosterone. Now, one of the hormones that is synthetically made is corticotropin. This is a synthetically made hormone, right? It is used to diagnose adrenal gland disorders. It is used to treat adrenal gland insufficiency. It increases cortisol levels in 30 to 60 minutes if adrenal gland is functioning. So technically, it is a chemical preparation which we give to our patient. It helps the patient's cortisol level prior to administration. Must draw a second cortisol level in 30 minutes after drug administration to see cortisol level rises. So we usually give it, and then we check in 30 minutes the level of cortisol to find out whether the blood level of cortisol have risen. And then persons with diabetes may need increased insulin, oral anti-diabetic medication, because the cortisol increases the blood sugar level. Now, corticotropin, the side effects would be sodium water retention. It will cause hypokalemia, low amount of potassium. Therefore, the potassium supplements may be ordered and monitor for weight gain and edema. Dose needs to be tapered and not stop abruptly. Adverse reactions for ecchymosis, and patients should call doctor if bruising occurs while on this medication. Hypothyroidism. What is hypothyroidism? Low amount of thyroid secretion. A decrease in thyroid hormone secretion is called hypothyroidism. Primary cause of thyroid gland disorders are decrease in T4 and elevated TSH. That could be caused by acute or chronic inflammation of thyroid gland, radioiodine therapy, excessive intake of antithyroid drugs, and surgery, which is thyroidectomy. The secondary cause is lack of TSH secretions. Myxedema. Myxedema is a condition of hypothyroidism, low amount of thyroid secretion. Symptoms are related with lethargy, apathy, bradycardia. So think about when you feel really lazy or tired. So that's a condition of hypothyroidism. It's like a laziness, just don't want to get up and don't want to do anything. That's myxedema. So technically more hypersense of it. So lethargy, apathy, bradycardia, which is low heart rate, memory impairment, emotional changes, slow speech, deep coarse voice, edema of eyelids and face, weight gain, dry skin, and cold intolerances. So the drugs contain T3 and T4 alone in combination are used to treat hypothyroidism. So some medication will be like, if there's less of hormone, we give them artificial preparation of that hormone, right? T3 and T4. So what are those? So in order to treat the thyroid disorders, we give them levothyroxine. Levothyroxine is a synthetic preparation of thyroid hormone. Maintenance dose is 50 to 200 microgram per day. It increases T3 and T4 levels, increases the metabolic rate and cardiac output. So it will just, think about being lazy and then you're like, let's get up and dance, So what is that? So that is basically we're giving them Synthroid that will just help them to get up and do things. So increases the metabolic rate, increases cardiac output, protein synthesis, and glycogenosis. Side effects include nausea, vomiting, anorexia, diarrhea, cramps, headache, weight loss, diaphoresis, and amenorrhea. Amenorrhea is loss of period, right? Okay, levothyroxine, also called as Synthroid. What are the food and drug interactions? It should be taken with empty stomach 1.5 hours before eating at the same time each day, preferably before breakfast. It increases the effectiveness of anticoagulants such as warfarin, something to memorize, read it multiple times, and you'll memorize it. Decrease the effectiveness of digoxin and anti-diabetic medication, including insulin. And we should monitor for hyperglycemia, could increase of the sugar levels. Avoid foods that inhibit thyroid secretions. What are those foods? Strawberries, peaches, pears, cabbage, spinach, Brussels sprout, cauliflower, radish, pears, turnip, and kale. Increases in the circulation of T3 and T4, which results from an overactive thyroid gland. The most common form is Graves' disease or thyrotoxicosis. Symptoms will include tachycardia, palpitation, excessive perspiration, heat intolerances, nervousness, irritability, exophthalmos, and weight loss. So someone with hyperthyroidism, they would have too much of T3 and T4. So think about someone who had like 7 cups of espresso, Starbucks coffee, and they're like super hyper. Let's go, get up and let's walk around. So that's hyperthyroidism. With tachycardia, palpitation, their heart rate is high, their heart is like running really fast. Like if you check their heart rate, it's like 120. And then excessive perspiration and nervousness and irritability. We used to have one of the lead nurse, and their eyes are like literally popping out. So the exophthalmos, bulging of the eyes. So that's hyperthyroidism. We used to have a lead nurse. She was so hyper, and she would want to know everything. She has so many questions for you. So if you work with her, it's like, oh my God, we used to be like, oh, good luck, she's coming. But the moment she would be there, she'd be like asking you, what is your patient's diagnosis? What did you do? This and that and that. And we're like, and her eyes were like literally popping out. We used to think like she has baseline hyperthyroidism, How could a person be so crazy? So that's just an example of hyperthyroidism, just thinking about a person who's just like up and just like, and they're like mostly skinny because they lose a lot of energy. They use all of their energy in their body energy, right? So we definitely need they need to eat more. They need food because they're like their metabolic rate or their energy burning capability of their body is very, very high. All right, so that's hyperthyroidism. And there are medications to cut the thyroid secretions, which we're going to talk in a little bit. Okay, so one of them is propylthiouracil. There's 2 or 3. Methimazole. Those are the ones which are anti-thyroid medications. Thyroid Armor. Okay, adrenal glands. Adrenal glands are, what are those? The crown on the top of the kidneys are called adrenal glands. Adrenal cortex produces 2 types of hormones, or glucocorticoids and mineralocorticoids. Glucocorticoids are technically, other words, is steroids. People take steroids to build muscles, and they exercise, and they're like, oh, we're doing steroids, and we want to do, when bodybuilders, they make muscles with steroids. So our body naturally produces steroids, and they are called glucocorticoids. And the other one is mineralocorticoid, also called as aldosterone. Remember, aldosterone does sodium water retention, right? So if a person has a lot of aldosterone, their body will be full of water and sodium, and they might have feeling of edema or feeling of fullness. Because of their influence of electrolytes and carbohydrate, protein, and fat metabolism, a deficiency of corticosteroids can result in serious illness or death. Glucocorticoids, one example is prednisolone. Prednisolone or cortisol has anti-inflammatory, anti-allergic, anti-stress effects. Can be given orally, IM, IV, topically in aerosol inhaler. It could be given in IM. So what is cortisol? Cortisol is technically a pre-made hormone, but some of them are artificially made. We make some steroids artificially. One of them is prednisolone. And prednisolone, it could be given PO, like a tablet form, IM, IV. We just don't give it through subcutaneous. Okay. Types of diseases treated with glucocorticoids are rheumatoid arthritis, myasthenia gravis, severe inflammatory conditions such as liver inflammation, asthma, allergies, contact dermatitis, anaphylaxis, oral, and then if a person has organ transplant. So let's say someone's kidneys were not functioning and they went to the doctor. Doctor's like, oh, you know what? We have someone who died and we have those kidneys available. If you wanna, do you wanna have a transplant? And they're like, yes. So when they get a transplant, so let's say their body matches and they would put a new kidney, take the old one out through surgery. Surgeons do that. So a person who is taking a new organ, replacing a new organ, has to take a lifelong prednisolone in order to reduce the amount of body's rejection, because the body will constantly reject something which is from somewhere outside. So in order to reduce that rejection, we have to take steroids, because steroids are immunosuppressants. They will suppress your immunity. They will not allow your body to fight. Immunity is like a fighting mechanism of your body. It's like fight, right? So like when we take steroids, they will reduce the amount of that fighting, which is like, that's why they are reducing the immunity power. So once the immunity is that there's not a lot of fight in the body, so it's able to accept that new organ in the body. So that is with organ transplant, we have to give them constant prednisolone in order to reduce the amount of rejection to the new organ. So must be tapered. So now all these steroids, when a person is on steroids, so let's say severe inflammation, because steroids have three major functions. They will reduce the inflammation, they will reduce the immunity, and they will increase blood sugar levels. Those three are major important functions, right? They must be tapered slowly. So let's say if a person had pneumonia, inflammation in the lungs, and they were taking some steroids, prednisolone for a little while. Let's say COVID positive patients, and then we sometimes order prednisolone. Take prednisolone for 1 week or how much time, whatever. All right, so let's say 1 week or 10 days, and after that let's say a patient was taking 10 milligram of prednisolone, so we will slow it down to 5. When 10 days are over, now I will reduce it to 5, then reduce it to 2, and then slowly taper it out. Don't just cut it off right away, because it could cause something called as adrenal insufficiency. Adrenal insufficiency is like adrenal gland is used to having some artificial hormone coming in, and it's just cut off right away. Then it doesn't tolerate it really well. That condition is called adrenocortical insufficiency, a decrease in the production of cortisol. It causes muscle weakness, nausea, vomiting, low blood pressure, and weight loss. Side effects of glucocorticoids. What are side effects? It will increase the appetite, weight gain, sweating, mood swings, flushing, moon-like face. Think about full moon. Moon-like face is related with steroids. Then buffalo hump. Then muscle wasting, decrease extremity size. Then it could cause peptic ulcer disease. The steroids are really, really bad for stomach. They can cause peptic ulcer disease. Petechia, which is what is it? Bruising underneath the skin. And hypokalemia, low potassium levels. So sometimes we have to give them high potassium diet. Drug interactions. If anything that could cause GI bleeding, they're bad for stomach. We don't want to give it with them. So what are those? Any aspirin, non-steroidal anti-inflammatory drug, they increase the risk of GI bleeding. Potassium wasting diuretics, they increase potassium loss, resulting in hypokalemia. Needs to monitor potassium level on a regular basis. Decreases the glucocorticoid effects with barbiturates, dilantin, and rifampicin, and needs a higher dose of steroid to offset. Blood sugar levels will be increased with steroids. Insulin and anti-diabetic medications will be needed to be increased. So those are just some drug interactions. Teaching. Take glucocorticoids with meal for less gastric irritation. So whenever, if you know that this medication could cause, that stomach irritation, it could cause GI bleed, so we don't want to do that. So we will actually, what are we going to do? We are going to make sure that we balance our meals. We eat proper diet with those prednisolone, or if we're taking any kind of glucocorticoids, we want to take it with food so that doesn't mess us up with my stomach, right? Eat foods that are rich in potassium. So what are foods rich in potassium? Nuts, meats, vegetables, fresh fruits, dried fruits, some bananas. Bananas, oranges are really high in potassium. Do not stop taking drugs abruptly, because what can it do? It could cause adrenal insufficiency. Okay. So this was all about steroids. So let's give you a little case scenario. So when a person's taking steroids, we want to make sure that they are, what do we want to make sure? That they are taking it with food. We educate them, hey, take it with food. Don't take any over-the-counter medications. Specifically, don't take aspirin or ibuprofen. That's not good for your body, because it could cause GI irritation. If you're taking anticoagulants, talk to your doctor, because it could increase the effect of anticoagulants. Take a lot of potassium-rich foods such as bananas. Eat more oranges. Fresh fruits, fresh veggies, nuts and meats, and don't stop taking those medications abruptly. Do the full course, and then at the end, slowly taper it off. Okay, that's the way of taking steroids. All steroids. Another condition is osteoporosis. What is osteoporosis? A progressive debilitating skeletal disease in older women and men. So what is osteoporosis? It's like when the bones become very weak, they're fragile, they lose calcium. And with people with older age, when they have, specifically for women after menopause, they have low amount of estrogen, progesterone. So estrogen causes strengthening of bones, and the bones lose calcium after reducing amount of estrogen. So a person who has what is osteoporosis? Is technically weak bones. Osteoporosis could be related with sometimes the hormonal abnormalities, and then low amount of calcium, not a lot of movement in the body. If a person's constantly bedridden, they might just have very weak bones. So if a person's not moving as much, and think about if they slip and they fall, they might end up having a really bad fracture. So that's why in older adults we see pelvic fractures or just breaking of the bones, just because when their bones are already weak, they're not moving as much. That's why walking is an excellent thing. It's a good thing to go for like 30 minutes to 1 hour walk every day at all age groups, specifically after 65. It's a good thing. So women older and 50-year-old are at greater risk of osteoporosis. Why? Because they lose estrogen, which is directly related to bone mineral density. It means it strengthens the bone. So when we don't have enough estrogen, we don't have enough bone mineral density, meaning the bones are not very strong, and it causes the loss of bone density, and then bone structure makes the person more at risk for fractures. Osteoporosis is just generalized weakness. So we know that when the bones are very, very weak, we will give them. So if it is related, if bone weakness is related with estrogens, all right, so we will give them estrogens. If it is related with, so there's another medication which is called as biphosphonates. So sometimes we give them biphosphonates, right, in order to replenish, strengthen the bones. Then there's medication called SERMs, and then some parathyroid hormones, because parathyroid hormones are calcium balancers. So with Fosamax, which is a biphosphonate, we would give them with 8 ounces of water. Get up in the morning, drink the medication with 8 ounces of water, and at least for 30 minutes. And it will also, person should remain upright for 30 minutes, because it can cause problems with esophagus, irritation, inflammation, ulceration, and that may cause more problems, right? So we just want to make sure that they're sitting up, they take the medication in the morning, and take it with 8 ounces of water. Okay, so this is, I'm going to do stop share here. Okay, so that was just a little review of Professor Lee's PowerPoint for week 7, but we have more information, right? So I'm going to continue this video. We are going to add on some more good stuff, which is some other types of. So we're going to talk about blood sugar control. So right. So let's do present. Very, very good. Hopefully it just uploads like that. Just very good. Okay. So chapter number 38 in your book talks about control of blood glucose level. Okay. So we know that pancreas is a leaf-like structure that sits underneath your stomach on the, the left side of your body, on your left abdomen. All right. So endocrine glands, they produce hormones in islets of Langerhans. Exocrine glands, there's other exocrine glands. They could produce, that's exocrine part of pancreas that could produce bicarbonate, some pancreatic enzymes, and it neutralizes acid, chyme from the body, and it helps in digestion. So there's something called a condition called cystic fibrosis, when people are not able to produce a lot of secretions in their ducts. So I had a patient like that who had cystic fibrosis. Mostly with patients with cystic fibrosis, they end up dying on you. Now, I had this patient who had cystic fibrosis who has been up and alive for 60 years. So usually those life expectancy of patients with cystic fibrosis is how much? It's like 15 years, 20 years. But this man is a miracle, living miracle. And he was, how old was he? He was 60 years old. He was a grandfather. He had a wife and he had kids, and he had a brother, and I was his nurse. They all visited him, and then he has tons of disorders. He has, his heart wasn't functioning very well. His obviously he had a disorder called cystic fibrosis, which he was born with that disorder, and his life has survived all of these disorders all his life. So he used to call himself a miracle, and yes, he was. And then he has to take all these pancreatic enzymes every day in the morning, because his pancreas does not produce enough enzymes, or they produce, but they're kind of, his ducts are blocked all the time, and they're not able to go to the GI tract. So he would take all of these pancreatic cells. Like when I give him his medications, they're like, the cup is all full of meds, and he would take it morning, afternoon, evening. He'll take all his meds. And whenever he would come to the hospital, he would be like, oh, watch me, being discharged in 3 days. Then I'll be on my boat and watching all those whales in the ocean. And I'd be like, wow, like he was such a positive character. And he would literally get out of all these conditions. He'd be like really, really sick. And then 2 to 3 days, you could just see him like getting better and then getting out of all those situations. So that was a story related with pancreatic enzymes, right? A very, very nice patient though. Okay, so with patients, you would know not only you apply your knowledge with them, but also like take life experiences, and they're like forever. Once you start working at the floor, you'd be like, oh my God, and they're just like forever experiences. Okay, let's get back to the PowerPoint. Okay, so going back to insulin, right? Insulin. Hormones produced by beta cells of islets of Langerhans. Insulin is something that your body or your pancreas produce. Beta cells produce insulin. They are released into circulation when level of glucose around these cells rises. They stimulate glucose synthesis, glycogen synthesis, and conversion of lipids into fat stored on adipose tissues, synthesis of protein from amino acids released after meals, causing blood glucose levels to fall. So whenever a person eats, let's say you just have a really yummy burrito, right? And then you have those chips with extra salsa, the avocado salsa on the top. Yummy. So now you had a lot of food, and then your blood sugars your body absorbed all of that food, and your sugars will be high unless you will have insulin going in. Your pancreas will secrete insulin, and they'll be like, okay, people, let's get to work now. So they will be just putting all that glucose back inside the cells, and then the cells will be producing energy and doing all the work what we're supposed to do, right? So all of that is related with, what is it related with? Insulin, right? Insulin reduces the amount of blood sugar because it pushes that glucose inside the cells and reduces the amount of blood sugar levels. And that's the function of insulin. Glucagon, on the other hand, when when there is too much insulin, glucagon is produced. Glucagon also is produced by alpha cells of pancreas. And what does it do? It will immediately mobilization of glycogen stored in the liver, raises the blood sugar level. So when the blood sugar level goes down, it will just store glucose. So whenever, let's say you were fasting and doing fasting and praying, and then what happens? Your sugars are low, you're like tired, you haven't eaten, you're like, oh, I'm tired. So your body will just, you lose weight after doing your fasting and praying. Why? Because all the body would slowly use the reserves, like so that, let's say there was some belly fat, you had like some fat sitting on the belly, the body's like, oh, we got a reserve here, let's cut it down and use it as an energy source. So that is the function of glucagon. So it will increase the blood sugar level and use the body stored fat, right? Okay. Now some of the terms we should know is hyperglycemia. So that we're going to talk about diabetes mellitus is a condition where a person does not produce enough insulin, or a person has insulin but the receptors are not functional. So they have the insulin but the receptors are not non-functional. So that is a condition where patients have high blood sugars, and that condition is called diabetes mellitus. Diabetes mellitus, hyperglycemia. Hyperglycemia is what? High blood sugar. Glycosuria, sugar in the urine. But should anybody be paying sugar? Not really. There should be no glucose in the urine. If there is glucose in the urine, that means the patient is running high blood sugar. Polyphagia, polydipsia, and polyuria are three characteristics of diabetes mellitus. Polyphagia is they want to eat more. Polydipsia is they're thirsty. And then polyuria, they pee a lot, right? Lipolysis is fat breakdown. Ketosis, ketones cannot be removed effectively. And acidosis is liver cannot remove all of these waste products. So acidosis is a condition. So ketosis and acidosis is when there's a lot of ketones, and they cause acidity in the blood becomes more acidotic. So it's a condition, ketoacidosis, which is a complication of very, very high blood sugar for a long time. So we're talking about diabetes. Diabetes is, it's a problem of a patient with high blood sugar. What's your normal blood sugar level? It is a 70 to 140 approximately. We would say 120, but clinically speaking, 140. If we don't give anybody insulin, so you probably know that whenever a person has diabetes, we give them insulin as a treatment, right? So what is the base level numbers of blood sugars? So look at clinical signs and symptoms is hyperglycemia, fasting blood sugar level greater than 126 milligram per deciliter. Okay. And then there are some other disorders that could generate because of high blood sugar, which is atherosclerosis, when a person will have plaques in their artery, retinopathy, which is like bad vision, because all of this high blood sugar causes the blood vessels to be not good. And then neuropathy, neuropathy is nerves which are not very functional because of excessive high blood sugar for a long time. And nephropathy is bad kidneys, right? So kidneys are bad, their nerves are not functioning very well, just numbness, tingling in the hands and feet. Retinopathy, the vision goes bad, and then atherosclerosis. So which could cause heart attacks and strokes. So not a good condition. So it's a good thing to control your blood sugar and keep it in a normal area. Classification. So type 1 and type 2. Type 1, when the body does not produce enough insulin. Type 2, they have insulin, but the receptors are like, we are not functioning with you. You know what? We don't like you. So we want to get like some medication that will just help them like each other. Let's like you, insulin and the receptors. Let's combine back. Let's join you back, rejoin, and go back to what you're supposed to do, right? So those are oral hypoglycemic agents. We're going to talk about them in a second. Clinical signs, symptoms of hyperglycemia. What are clinical signs, symptoms of hyperglycemia? So if a person is having very, very high blood sugar, they might feel tired, lethargy, excessive sleepiness. Like if a person's like too sleepy, it's a good thing to check your blood sugar. Irritability, it's like, oh, he's irritated with this person. Not really. Check your blood sugars also. Are you low in your blood sugars, or are you high in blood sugars? Glycosuria, blood sugars in the urine, Polyphagia, polydipsia, polyuria. Too much urination, too much eating, and too much drinking water. Itchy skin, very dry and itchy skin. Why am I itchy all the time? Check your blood sugars. And if a person develops a complication if a person develops complication of diabetes, then they might have something called as ketoacidosis. Ketones are made, and ketoacidosis causes fruity smell in the breath. It could cause severe dehydration. It will slow down the respiration, causing Kussmaul's respiration, and it will cause patients' level of consciousness to change. They might be disoriented. They might be not knowing what they're doing. So that is their alert and orientation status kind of changes. Coma, they lose consciousness. They go in a different area. That's not good at all. Hypoglycemia, when a person's blood sugar is low. So think about, you have exercised for 3 hours, you've gone to gym, and you're like, you know what, I need to lose my belly fat, I need to be skinny, I need to be pretty. So you're like, oh, I'm going to exercise today. And now you're in the mode like, you're doing exercise, and now you forgot to take your drinks. You did not drink water, or you did not take your snacks. Well, let's say it's a good idea to have like some kind of protein snacks if you're exercising. Like, there's protein bars, protein milk. You can do that in order to balance, that not just very low blood sugars. If a person's blood sugar drops, what do? We give them more sugars to drink or eat. So we can give them something called as, what can we give them? We can give them a glass of orange juice. We can give them, let's say, if they're milk, 8 ounces of milk, or protein, any kind of protein, that might just increase their blood sugar. Now, if a patient loses consciousness, then we end up giving them, we can give them glucagon, we can give them 50% dextrose IV. Those are the medications to treat severe hypoglycemia. Which of the following is a clinical manifestation of hyperglycemia? Do they have edema? Do they have lack of thirst? Do they have itchy skin? Do they have hyperexcitability? So they don't have edema. They are actually very thirsty. They do have itchy skin, and they're lethargic on the other hand. So the answer is itchy skin, right? Itchy skin, yay. Okay, rational. Clinical signs and symptoms of hyperglycemia: fatigue, lethargy, irritation, glycosuria, polyphagia, polydipsia, and itchy skin. Yes. Okay, now we're going to talk about insulin. Insulin is a hormone that promotes the storage of body fluids, facilitates the transport of various metabolites and iron across the cell membranes, and it stimulates the synthesis of glycogen from glucose. So what does it do? It technically reduces the blood sugar levels, right? Insulin. It could be used for type 1 and type 2 both, depending on if a person's, and there's times when insulin doesn't work as much. We also give oral hypoglycemic agents. Okay. So it is a thing to know whether a patient's pregnant, they're lactating, they're having any contraindications, means they have any allergies or any severe other conditions, baseline conditions, before we start giving them insulin. Okay. So that's just a baseline assessment. So I checked my patient, I did my history and physical, I'm about to give insulin. Hey, are you allergic to insulin? Patient's like, no. And then, have you ever taken it? No. Do you exercise regularly? Not really. And then, you need to exercise, but okay. We're going to give you this medication, which is called insulin, right? Now, insulin comes in different forms. So if you look over here, it has like different kinds. They have regular insulin, which starts working. Let's say insulin comes in a short, like a subcutaneous injection form. So if you see regular insulin onset is 30 to 60 minutes, peaks in 2 to 4 hours, and duration is 6 to 12 hours. NPH is 1 to 1.5 hours, 4 to 12 hours, and 24 hours. Then we have Lispro, less than 15 minutes, 30 to 90 minutes, 2 to 5 hours. So what is that? That is literally like, when does it start functioning? When does it peak? Meaning when is the max effect, and how long does it stay in your system? So these are just different kinds of insulins, right? Sulfonylureas are tablet forms of medication that will cause, how when insulin and the receptors don't get along, the receptors like, we don't like you, I don't like you. Insulin says, I don't like you. So we have to send them something like that. We'll just put them together, like, you have to like each other, you're made for each other, okay? So those medications are called sulfonylureas. So sulfonylureas, there's tons of different ones. So first, sulfonylurea is, remember this one, tolbutamide, very commonly used medication, and also chlorpropamide, all right? So second generation is glimepiride, glipizide, and glyburide, all right? So these are just the classification of these drugs, so not necessarily you don't have to memorize it, but just know them, right? Action, what do? They would stimulate the insulin release from the beta cells, and they improve the binding to the insulin receptors. They're the one that goes in the middle. They're like, hey, like each other, come back to each other, that kind of stuff. So those are sulfonylurea. Pharmacokinetics is rapidly absorbed from GI tract. It is excreted in the urine. It peaks at a specific time. We want to make sure that they're not allergic to the medication. They do not have diabetes complication. We just want to check for any adverse effects of all of these medications are hypoglycemia, GI distress, allergic skin reactions. We want to make sure that there's no other drug-to-drug reactions could be related with beta blockers and alcohol and drugs that could acidify urine. Some sulfonylureas are chlorpropamide and glyburide. Question. Second generation sulfonylurea have several advantages over first generation sulfonylurea, including the fact that they interact with more protein-bound drugs. False. All right. Okay. So other anti-diabetic agents, there's some other ones which are available. I'll remember for all of them. One is metformin. Metformin is a very commonly used medication. All right. So metformin is specifically given. We want to make sure that the person does not have any kidney disorders when we give them metformin, because metformin could cause kidney damage. Okay. So whenever patient's getting a dye or any dye-related, let's say, procedures, we don't give them metformin. We hold metformin for 42 to 72 hours. Okay. Other glucose-elevating agents are dioxide and glucagon. Now, when a person is having low blood sugar, we give them something called as glucose-elevating agents. Okay. We could give them. We want to make sure that they're not allergic to it. They're not pregnant or lactating. We do a general assessment. A question on it is, which of the following is a primary action of glucose lowering agent? What does it do? Accelerates the breakdown of glycogen, increases the insulin release, improves the binding to insulin receptors, and decreases the incretin. It accelerates the breakdown of glycogen. Now, this is a picture which I chose just to show you. These are the areas where we give insulin: on the arm, on the belly, or in the front of the thigh. Insulin injections could be given on all of these sides. There's something called as lipodystrophy, which is like the body fat. Like if patient's taking constantly insulin, the fat kind of gets necrosed or like dry, like it gets like kind of thick. So that condition is called lipodystrophy. That could happen with constant insulin injection. That's just so we rotate the side. One time we give them in abdomen, one time we give them in the arm, one time we give them on the thigh. Insulin injections kind of look like this. They come in the pen form. This you see Humalog. When you go in the clinical practice, you will see, oh, this is how that looks like, and these are the pens available, and this is just a picture of it. Now, this table just basically tells you different kinds of insulin. There's like Humalog, Novolog, Epidra. They are rapid acting. They work in 10 to 30 minutes, and 30 minutes to 3 hours is the peak time. In duration, it stays in your body for only 5 hours. After that, you need more. Like, okay, if you got a Humalog shot, if you've given a Humalog shot, after 5 hours, you will have to give another one. Okay, short acting. Thank you. For short acting insulins, regular insulin, which is 10 to 30 minutes onset, and then peaks in 2 to 5 hours and up to 12 hours. Intermediate acting insulin are NPG. It starts functioning in 1.5 to 4 hours, peaks in 4 to 12 hours, and up to 24 hours. And long-acting insulin are also called as Lantus, which is onset is 0.8 to 4 hours. It starts in 4 hours, and it's there for 6 hours, and then it stays in the system for 24 hours. So meaning, like, if a person gets one shot of Lantus, they're good for 24 hours. But they know that this doesn't start functioning right away. It takes 4 hours to function. So sometimes we give them a combination. We'll give them a Humalog, and then we'll give them a long-acting Lantus. Insulin also comes in a pump form. Sometimes we insert a needle on the belly and then it just sits over here and it constantly injects like 1 or 2 drops of insulin in the patient's belly fat. Okay. This is another table which talks about, regular insulin starts working in 30 minutes, peaks in 2 to 4 hours, and duration of action is 6 to 8 hours. Clinical consideration, take 30 minutes prior to eating. Let's say whenever we give them insulin, we want to make sure that we bring the food right next to the patient. We also ask them to check for signs of hypoglycemia. What are signs of hypoglycemia? When a person's like feeling weak, shaky, nervous, irritability. Those are signs of hypoglycemia. So if they start having signs of hypoglycemia, we want to give them some snacks. So before, like if they start feeling like weak or generalized weakness, we want to balance. The word is balance, balancing off the blood sugars. So I think that's the last slide which I wanted to share with you. And this lecture was technically related to just a review of Professor Lee's PowerPoint and also some insulin. So thank you for watching, and I will make one more, just a few more videos, just to review all the endocrine system. So it's a lot of information. It could be information in overload. So I would highly suggest like take a good 15 minutes break, get up, walk around, do a little bit of movement in your body. If you like music, listen to music, take a little break, and then watch the video, another video, which this is technically video 2. You can watch video 1, you can watch video 2, and then the best thing in your recorded videos is you can watch them multiple times to help you understand. You can slow it down and then play it at your own speed. Okay, thank you for listening, and we'll catch up later.